kind of what she sees in her world when she's working. Now, when the real world versus the testing world is where most people struggle. And I have the most brilliant-minded ER and ICU nurses who I used to teach ACLS to that just would get pissed off, is the only way I can tell you. Because American Heart tests in what you do next and what you do next. And in the real world, really, we're doing it all at once. And so the most brilliant minds, doctors and nurses, hate being tested on order because it's stupid, because in the real world, but the reason you're tested on order is because if you can't do it all at once because you don't have a team of people, what should you do in what order? And so that's when I don't want y'all to think that Ms. Cooper is not realistic, but we have to teach you to pass NCLEX. But I want you to go, not to go in the hospital and go, well, you're supposed to do it this way and this way and this way, because you're going to make yourself look bad if you do that. So I don't want you to look bad either. So in reality and on your test, on a nasty morning is the correct order of Mona, all right? But in reality, you're probably going to see it different ways. Now, all right, we'll say we come in the ER, we did the on a nasty morning, and we were waiting, we got our 12 lead back. What on that 12 lead, or even on your telemetry, what area of your waveform on the EKG should you be looking at? SVT segment, and we don't see any evidence of an MI on the EKG, on Jack's EKG. What's some other things on that EKG? What other wave might give us a hint? T wave. If the T wave is inverted, then that could mean ischemia, okay, of the myocardium. Could. So that is EKG evidence of an MI. What other evidence are we waiting on? She's waiting on the blood. And so with the blood draw that we hopefully remembered to get when we started our IV and sent it down for our enzymes, we're going to say his first set, because we're going to do 3 sets or more, was negative. So Jack is like, hey, I got somebody at home. I need to go home. I got things to do. I'm still hurting. If there's nothing wrong with me, give me something for indigestion. Let me go home. And so what do we tell Jack? No. What do we explain to Jack about the enzymes that I told you earlier? Okay, and that it's real important that he stays. Now, what other test might be ordered if there's no evidence that he's had a heart attack? We're trying to figure out what's going on and make sure we can clear his heart. Maybe he only has problems when his heart is stressed. Stress test. So there are basically 2 flavors of stress test. One is an exercise tolerance test, which we don't call it that at the hospital. They're either going to call it a stress test if they're going to do an exercise stress test, where Jack will have to walk on the treadmill, or they're going to, if he don't have legs, or he only has one leg, or he's not, he's unsafe to get on the treadmill, then they're going to do what's called a pharmacologic stress test. So those are the 2 kinds. It's either you walk on the treadmill, which is an exercise, or you're going to do a pharmacologic. And at Singing River, we call the pharmacologic Lexi scan. And so they don't even say a pharmacologic stress test. They say, I'm sending the patient for a Lexi scan. Lexi scan. And that is because that is the trade name for regadenoson which regadenoson is the generic name for Lexiscan, and you don't have to know that because it's not in your book yet, and I'm shocked. So, but I want you to understand the concepts, because no matter what agent they tell you on your NCLEX they're using, let me tell you what the agent is going to do, no matter what it is and what it's called. I think in your book it says persantine and dobutamine. So what it does, what happens to you when you get on a treadmill? Your heart rate increases. Your heart rate increases. What else happens to you?
Sweat.
You get tired.
Sweat. You get tired.
Your respiration's
Breathing.
Thank you. Your respirations go up. I hope they do. I do. All right, so let's talk about something. What happens in your heart when you're on a treadmill is that you are increasing the demand on your heart muscle because it has to. All right? Right. And so it needs its oxygen. So what happens is if your coronary arteries are pretty healthy, they are going to dilate in an attempt to get more oxygen to that heart muscle. Okay? Now what about that old person or that person with coronary artery disease that has horrible diseased coronary arteries and that plaque's hard and rigid? Are their arteries going to be able to expand when they're on that treadmill? So what we will see, no matter which test it is when we stress someone's heart, sometimes we start seeing EKG evidence of ischemia while they're doing it. So there are a couple of different portions of a stress test. So let's talk about that in just a minute. Divisions, you should say. I just told you what happens in the heart when you get on a treadmill, didn't I? What happens is supposed to happen to normal vessels is they do what? They dilate. So if you can't walk on the treadmill, the medications that we give you during a pharmacologic stress test do just that. Lexiscan, otherwise known as regadenoson, it dilates vessels. It will scare the heck out of your patient when you give it to them. I used to do this in my last job. We did so many Lexiscans. I had one guy, and I will never forget him. He was from the jail, and he was very young, and he goes, "Do it again. That's a better high than any drug I've ever injected." He said he felt like he was coming up over the top of a roller coaster. And he said, "That was awesome. Do it again."
Oh my God.
Most people don't have that response. They sweat. They feel like they can't catch their breath. It's like almost a doom feeling. And so I always warn the people that I did it to, now look, don't be frightened. This medicine is going to make your heart go from 0 to 100 and something within seconds of me pushing it. It's supposed to do that. I'm right here. I have something to reverse it with. There's an antidote that we have right next on our little bedside table thing. There's an antidote. It's aminophylline. And you can reverse it within seconds. That's what we have to do if someone becomes very symptomatic. Or if you're a nice nurse and they're telling you their head hurts already, I just go ahead and give them some aminophylline. Because after the test, it wasn't mattering. And so, again, according to the agent that you're using, and this is where you're going to have to find out what your hospital uses and look it up. But Lexiscan is contraindicated if you have asthma. Lexiscan is or bad COPD. It's contraindicated. We would not do a stress test, a pharmacologic stress test on somebody pregnant. I hope that makes sense. So, again, what are we trying to do to the heart rate when we're having a stress test?
Increase it.
Make it go up. There are some well-trained athletes who you couldn't get their heart rate over 50 if you tried. And they could run for hours on that treadmill. And they will demand to have an exercise stress test because that's what they do. And you have to explain as the nurse, it will be ineffective. You won't be able to do it. There were two areas at Singing River that do stress tests. One is the non-invasive cardiology and the other was radiology. Radiology did pharmacologic. And cardiology did the treadmill. Well, there was this one man who was a runner and an attorney, and he was mad, and they were like, God help us. I'm like, okay. And he was almost cussing them out because they told him he failed his stress test. Because he was mad, because he could run. I run every day. I didn't fail my stress test. Y'all said it wrong. This type of testing is ineffective for you, sir. You're going to have a pharmacologic stress test. The med can elevate your heart rate, but running on a treadmill is not going to. And so I finally coaxed him over to the other side, and we did a pharmacologic stress test on him. Now let me explain what's going to happen with your patient. If they have coronary artery disease, and we know it, and it's somebody like Jack, is it a nerve, y'all, that we are going to stress somebody's heart that we're afraid is already diseased? That scares me to death.
Why do they have that on
So listen, wait a minute. So listen, let me finish. We must, as nurses, if they are inpatient, have 2 sets of negative enzymes on a patient before we stress their heart. Because if their enzymes peak up, what does that mean? Like they were negative, the first set was negative, but the second set is now positive. Does he have an active process going on in his heart?
Yeah.
Does he need to be stressed? Could it kill him? Yes. We should not be stressing a damaged heart like that. With an active process, y'all heard me say active process going on. So if your patient who come in, Jack, who came in through the ER overnight and was no longer having chest pain, is scheduled for a stress test, and that morning they come to get him, and you're helping him get his shoes on, and he says, my chest hurts. Do you send him? No, that would contraindicate a stress test of any kind if they have an active chest pain. What other things going on with a patient would make you say, no, you don't need to go? I don't care. I know it's ordered and they're down there waiting on you, but you're not going. High blood pressure. What if their blood pressure's through the roof? Do they need to go down there and have a stress test? No, we need to call the doctor and get some medicine to decrease the blood pressure and then send them down when their blood pressure is normal. Now, there's a couple of other things that would have me very concerned if their heart rate was very low or very high. We will question sending them for a stress test. All right. Do they need shoes to walk on a treadmill? Yes. Do they need feet? Yes. They do. If they're 80 years old and you're helping them get to the bedside commode, do they need to get on the treadmill? No. You will be shocked how many of these tests are ordered on people who cannot do them. And you are going to have to pick the phone up and say, hey, don't think you realize you only got one leg. Hey, we can't always get this lady on the bedside commode. You may want to change this order. And the way they do it at Singing River is the order will read GXT at Singing River. On the computer, it'll say GXT. And that means gated stress test, and it just means walking on the treadmill. It's an exercise stress test. And I just put that up because a lot of places do that. And I just want to make sure you were aware. Now, there are certain things we got to make sure for the patient Jack to go for a stress test. Does he have to be a PO? Yes. At least for a couple of hours. If we're going to do it and it's going to be noon, we may give him a liquid breakfast or something. But at least for a couple of hours. As far as meds, we talked about beta blockers and calcium channel blockers slowing the heart rate, didn't we? You don't give them those medicines and then send them down there hoping that their heart rate's going to do what? Elevate. If I went for a stress test, I would not be able to take my medication. I would have to take it after the stress test. Because with the stress test, our whole target is to do what? Stress the heart, increase the heart rate. And if the heart rate does not elevate during the test is ineffective. So if I go down there for a stress test and my heart rate won't get up almost twice of what it normally is, typically they want it 80% of what it is. Higher. It's high. We want it high. We want to stress you out because if we want to know if something's going on with your heart. We want to clear you. Okay? So we want it up and we want it high. So what medicines are you going to hold?
Beta blockers.
So post-care after someone has a stress test, what do we tell them? Anything? Bye. Good luck.
Take your
Report
medicine.
any chest pain.
Report any chest pain, any discomfort, and do not go get in a hot shower for a little while. Why?
Because it dropped. It like.
Same reason you shouldn't get off the treadmill and run straight to the hot shower, but at my gym, that's what they do. I'm like, y'all done fell out in that sauna back there. Go ahead. Because you dilate your coronary arteries, don't you, when you run on the treadmill? So now what happens in the shower when you get in a hot shower? Same thing? Okay. So this slide is talking about walking on a treadmill, exercise stress test. Y'all with me? The next one is a pharmacologic stress test, and in your book it's going to say quercetin and dobutamine. We don't use dobutamine in the real world unless someone has a contraindication to taking Lexiscan, such as asthma or bad COPD. We rarely use dobutamine. But for any farm stress test, do they need to be MPO? Yes. Same thing. Do they need tennis shoes? Because they're going to be on a stretcher. They will be injected with something called MyoView, which is an isotope, and the person that does it will carry it. It's a radioactive isotope in a syringe, and it's in this little thing called a pig. It's very heavy from radiology, and the nuclear medicine techs will carry them in their hand, and they'll walk to your patient's room in the hospital, and they will inject it right in their IV, and you may not even know it. And this is the isotope that they're going to use when they take them for their nuclear med scan. This is an example of it. So a farm stress test has a couple of different steps to it. So they make sure the patient's MPO and not having any active problems, any stress tests, any way we stress the heart, we can't let them have any stress going on at the moment. So nuclear med techs are going to inject them, and then they are going to scan them before their stress portion of the test. So do you see, I don't know if you can see it, but this patient's arms are above their head because they're trying to scan around their heart. So if someone has a broken arm, is that a problem?
Yeah.
So anyway, so they're going to bring them down and they're going to scan them and they're going to follow this isotope. And the radiologist will be able to look at the scan and see if there's any ischemic tissue that is taking, that looks differently on the heart related to that isotope. They'll call them hot spots or cold spots. It's according to which kind of isotope they use. You don't have to know that. All I want you to know is they're going to do a nuclear med scan, and they're going to scan the heart before it's stressed and look at it and see if there's any ischemic areas. And then they're going to stress the heart. And then within those 2 hours, they're going to bring the patient back. So let's say you're the nurse and you injected Jack. Oh, sorry. You injected Jack with the stuff. And he said, oh my God, you're trying to kill me. And he recovered. We have to make sure their heart rate gets back to normal before we send them out of the stress room. And so you send him back to his room. You send him back over here. And he said, I'm hungry. Can I eat now? He can. After the stress portion, your patient can eat when they get back to their room. And if you're a nice nurse, you'll bootleg them some caffeinated something, because LazyScan causes dilation. What do you think it also causes? Headaches. And so, you know, the nurses were all new where I used to bring patients back on one floor. I'd make a diversion and find coffee in a waiting room before I brought the patient back, and I'd say, just tell them it's decaf. And because, gosh, your head hurts so bad after that. But the caffeine causes what? And takes care of the headache. Okay, anyway, don't tell nobody to do that. And so then, again, here's some of the contraindications to having the stress test up here. Why should the patient not have caffeine, nicotine, and alcohol before any stress test? Right. I'm just making sure y'all reading up here. If it's a pharmacologic stress test, do they need an IV? Because how are they going to get the medicine if they don't have one? But what if I kill them? I guess they'll need an IV, so I can do what?
Save them.
Save them. All right. So, what if Jack tells you all of a sudden he don't feel good? Can he go down and have his pharmacologic stress test?
No.
Y'all, it's really hard to grow you something. Who knows? But you're going to have to be your patient's advocate, because if he tells you he don't feel good, and you send him down there and he has the big one down there in the stress test, whose fault is it? Yours. Okay, make sense? Okay. So are you kind of understanding some of the reasons why? What's the prep before a stress test? Are they MPO?
Yes.
Are they, what kind of clothes do they need? If it's exercise they need, if not,
Whatever they're in the
okay,
bed.
good. No matter the type of stress test, they need an IV. You with me? No matter the type of stress test, they need to be MPO. No matter the type of stress test, you need to make sure they have 2 sets of negative enzymes. Now, sometimes, don't freak out when I'm fixing to tell you something that might freak some of you out. The black and white people are going to be freaked out. Sometimes cardiac enzymes will be a little bit elevated on patients who have history of heart failure or history of renal disease, dialysis patients, because they have damage to their heart already. It doesn't mean they're having a heart attack. The reason we do enzymes times 3 every 8 hours, times 3, and sometimes more often, is because if they're having an active event or event at the moment, a current event, or an MI is what we're concerned about here, those numbers, even the person that's always a little elevated will do this, go way up. Okay? That's why we want how many sets? 2 at least. And because let me tell you, the person pulling the trigger down there on that syringe used to be me, and I'd be like, oh crap. Looking at their enzymes going, well, you already got a little damage, here we go. You know, but they have a history. So that's normal for them. So don't ever say on the floor, nope, my patient can't go. Their enzymes are positive. They can go as long as it's not new and it's a trend. And at most facilities, you can look back months and see. And typically on those patients who have those positive enzymes that have renal disease or a heart failure, they'll be elevated every time you look at them, but they're going to be almost exactly the same every time. All right? Make sense? Okay. All right. That's pretty good notes up there, isn't it? Now, we talked about the nuclear scan before the stress, right? And we brought Jack back to his room and let him eat. Well, then them little nuclear med techs come get him again. They go, come on, we got to go scan you again. And he goes, really? I just did that. They scan again after the stress. Guess what they do with the films?
Compare them.
They compare them. And sometimes that's when they fail their stress test. They may have done perfectly fine, no ST segment change during the stress test. They're hooked to a 12-lead EKG, whether it's an exercise stress test or pharmacologic, the whole time they're down there. We take vital signs every 1 minute while you're getting your attention. Every 1 minute. So you can fail your stress test during the injection or while walking on the treadmill if you have ST segment changes, right? That's obvious. Or if you start going, oh, I feel a big one coming on. Elizabeth, I'm coming to join you. If you saying that, then you failed, right? Or if you get nauseated and start trying to puke all over the nurse, then you failed. We'll reverse it. We'll stop it. We'll pull you off the treadmill. If you did fine there, you go get the scan, and there's a big difference between before we stressed you and after we stressed you, you failed your test. Okay? The reason I'm telling y'all this is I made the mistake when I first started down there. There was the cutest little old woman. She looked like Tiffany. And I mean, she was tiny and she was precious. And I told her, I said, you did so good. Because she was scared, you know, and we did her stress test. She did great. She went back to her room and she ate. And she was so happy. And then they come and got her and they scanned her. And her scan looked horrible. Her post-stress scan looked terrible. So the doctor goes in and tells her, ma'am, you got to have a heart cath. That's the next step. She demanded. She knew my name. Go get her. She told me I did fine. Don't ever say that. Because, yes, she did fine in the portion I did. But you can do well during the stress test, pharmacologic stress test, but if your scan shows that you have ischemia following your stress portion, is there a problem that needs to be investigated? Yes. So how are they going to investigate the inside of the coronary arteries?
With those cows.
You're going to have a heart cath. So again, not all stress tests, especially on women, are valid. Isn't that interesting? So a lot of women, they'll do, instead of putting them on a treadmill, you'll have an echocardiogram. You'll have something called a stress echo, where they do an echo on you, and then you run on the treadmill, and then you lay on the thing, and they do an echo after. It's really interesting. So there are other tests that they can do, but what are we learning here? What have you learned about so far? A stress test. I assume you understand that during a stress test that the patient, they do a 12-lead EKG before we start. Then you're hooked to a continuous 12-lead EKG while you are on the treadmill or on the stretcher. And that's how we're watching for any ST segment changes. And the machine will do it for you because the nurse is watching for blood pressure and pulse and respiration the whole time, every 1 minute. Do you think she can watch the 12-lead too? Thank God there's a tech there and that the machine will holler if it changes. So again, what are the safety and what are the take-homes? You ready? What do you think a question might be like about this?
Patient has a blood pressure of whatever, and they're coming to get them for a cath lab.
Right?
I mean, not a cath lab, a stress test.
What assessment finding would cause the nurse to stop the procedure? Chest pain would be a reason to stop. What else would be a reason to stop a stress test?
Positive enzyme.
Elevated enzyme, ST segment change, elevated. What if it elevated during the procedure? Y'all think that happens?
Stop and go to cath lab.
Yep, it's happened.
Go straight to the cath lab and it is elevated during the stress test?
Yep, you getting a ticket, a one-way ticket. Out of my room. You've done it now. Okay. What else would cause me to stop a stress test? I'm the nurse doing the stress test.
Vital signs change.
The patient states, oh, we're already doing it, or before?
Or I don't feel good.
We're doing it.
Their heart rate drops.
Heart rate drops. They start vomiting. They pass out.
They call it on.
Okay. So are you understanding how you're going to be tested on this? Now, what are some things? What's teaching a patient before? What do they need to know before a stress test?
Let us know if anything is different the morning of.
Don't take the medicine.
Don't take their beta blockers.
Don't even-
Good. So make sure you read these notes again, right?
Yeah.
Okay. So now, let's talk about, do they need an IV?
Yes.
Okay. They're doing pretty good. All right, heart cath. Oh, Jesus. Now we doing heart caths and all kind of arteries. Main one that we're going to look at and cover is femoral artery. Where's your femoral artery?
In your groin.
In your groin. The reason I like to do the groin is because it's a larger, straighter shot. Larger vessel, straighter shot. To do a complete heart cath, where they're looking at both sides of the heart, getting all kind of pressures, and they have to do a complete heart cath in preparation for a cabbage. Okay? So if I think that patient has a diseased heart, then I'm prepping their groin. And at clinical, a couple clinicals back, we had the weirdest man come in, and he had poor venous access. The ER had to stick him 6 times to get an IV in him. And he was a psych patient too, by the way. And he had failed his stress test. We were on PCU, and he said, I'm having a heart cath. And the nursing staff said, go ahead and prep him. And I said, this will be great for my students. Okay. And so we go get the clippers after we find the head to the darn thing. Y'all know how hard that is some days. And so we got the head to the clippers, and my most bashful student, the man, and he was hairy. And so I said, let's clip his groin. And so she goes, and I said, we want him to look right. And she like, so we shaved him on both sides, and I said, now we need to check his IV. She said, why would you check his IV? I said, he's going for a heart cath. We want to make sure if something happens to him, he's got a good IV. Plus, they said he had it since he came in. Of course, his IV was bad. Y'all know his IV was bad. And she was like, but they said in report it took him 6 times to stick him. And I said, it's going to take you one. Go get the stuff. And y'all, it took me forever to find a vein to even stick, which told me the man had
IV drug use.
no. Told me he had poor venous access, and told me really that his cath was not going to be easy. So we found a vein, and that girl was so scared. I knew she was going to get it, because God knows she'd have fell out if she wouldn't have got it. So the man was like, you got one stick. You know them. And I said, oh good, we got this. And she was like, really, Miss Cooper, we don't have this. And she got it. I was so proud of her. And so we got the IV. And here comes the cardiologist. Y'all, this is just priceless. So he comes in here and he starts telling this man what he's going to do. And he's doing this. And we're going to stick you right here. I'm looking at him thinking, yeah. And so my student is getting paler by the second because she has just shaved this man's groin. And so I'm just standing there. And so the doctor walks out, and I wouldn't leave her. And she goes, and the man goes, and why did you shave my groin? But he did it in this like weird way. And I said, and I wanted to say, because I wanted to, but I didn't. I said, because, sir, if they can't navigate that wire, they're going to have to go stick you in your groin. It's just, I'm just telling you. It's a preparation that we do to everybody. I'm lying. And so, anyway, So they come get in. This is how this ends. You know, we're there for 12 hours, and she was like, please, God, don't let me be here when he gets back. But she was. So we were walking off the floor to leave, and here he comes. And he does this, and, you know, you're not supposed to. He goes, hey. She's like ready to run. And I go, come on. And so we walk over to him. He goes, you were right. They ended up sticking both sides, and they had a horrible time. And I figured they would. I mean, if you only have one vessel that we can stick here, does it make sense that your vessels are probably not very easy to navigate? He ended up going for an emergency, almost emergency. They did it very next morning, cabbage. He had like 100% blockage of some of his major vessels. He was a very lucky man. And but anyway, just because the doctor says they're going to stick them radially, they may not be able to navigate that wire where they need to get into the heart. So sometimes they intend to go radial, but they end up femoral. And I think y'all need to know that. Now, the differences are, with the radial sticks, of course, they're just going to have something called a hemoband, which is a band or some sort of pressure band, and we'll release it every 30 minutes. And it's typically about 2 hours that's kind of immobile. And they, of course, don't have to stay on bed rest because it's their wrist. With femoral, bed rest is very important. Does that make sense? Mm-hmm. And so there's a huge bleeding risk. But it doesn't matter. No matter where they stick, what is our priority? Is we don't want them to bleed. They can bleed to death. If they get up and put pressure on their leg, they can pop that little bit of a clot that we held pressure after the procedure. It's an artery. And the bleeding sometimes is not outward that you see. Now, I have seen it shoot the roof. I don't like that. So sometimes we see outward bleeding if they break loose and bleed. But sometimes we see nothing but a big old goose egg coming up at their groin. And are they bleeding? Yes. Where is it occurring? Under the skin. I have seen patients, and I don't think he cares. Reggie, do you care if I use you? Patients Reggie's size, they can lose a couple of liters inside them and you not even notice if you don't pull the darn covers back and do your assessment like you're supposed to. Following a heart cath, we assess the site and the distal pulses every 15 minutes for the first hour. So the priority after a cath is the site, the puncture site, because we got to make sure it's not bleeding. So not only do we look at it with our eyes, we feel it around it with our hand to make sure it's not getting tight in there. Because if someone's bleeding under there, is that a lot of pressure coming up? So it's going to change how it feels. And so the first thing that when a cath lab nurse brings you a patient back from the cath lab, you do is you're going to start looking at the groin. I mean, have you met them yet? Sometimes you're ever going, well, let's see here. But you're looking, what are you looking at?
The bandage and the
You're looking at the site. Right, the bandage, making sure you don't see no outward blood. And some people are going to have like a little lump under there according to what kind of device they used. So you got to know what normal feels like so you would understand what abnormal is. And let me tell you, there's some people that make Reggie look small that have heart caths sometimes. And it's hard to tell. You over there trying to pull up this apron and the next apron trying to find the spot. And then you got to feel real good to make sure you know how it feels so you would recognize if there was what? Bleeding going on underneath. So the two big, your priority is circulation. And checking for bleeding and checking distal circulation. So what if the pulses, how do you, look, I love to ask y'all this. Oh, Jesus, I hope you were taking care of the patient before they went, because we mark their pedal pulse with a marker. Because some people's pedal pulses, they're hard to find anyway, aren't they? Mm-hmm. And now after the heart cath, you got to know whether they're the same. You're like, oh my God. And so having those marks, we mark the pulses before they go, is wonderful. isn't it? And so what if you went to go check a patient after a heart cath and their pedal pulses were like 2+? They weren't great, but you could feel them and find them. And now you're putting your finger on that same X mark and they're like 1+. So what do you got to do? What else? What would you do at that point? Get somebody to double check me. But what other assessments could you do? High five, girl, high five. Karima is one of the most common sense persons, and how she says it's so pretty. And that's her little, whatever that is she's got. She's one of those people that can cuss you out, and it sounds nice. And you're like, okay. But anyway, she said, check bilaterally. Are they both like that? The other thing you want to do is what's the color and temperature of that leg, right? Says if I get a pulse change, if there's a perfusion problem, are you also going to have problems with the temperature of the leg, the color of the leg? And my favorite thing to do, Karima, when I have a heart cath patient, is I pray they have 2 legs because I like looking at both of them. Because you can see a change, because both of your legs kind of look alike, don't they? Mm-hmm. Most people's do. So you can tell they're having a change by comparing them bilaterally. But what is the priority with a heart cath patient post? Where's the first thing you're going to be looking at? And distal circulation. And if their pulse changes, you're going to check the temperature and color of the leg. And what else could you check on that leg or foot? Cap, refill. Tells you about perfusion, doesn't it? Does that make sense? Now let's talk trash. What do they inject during a heart cath that a lot of people are very allergic to? So come on, you guys. We know they have to be NPO for a heart cath, right? Y'all understand that? Because if they struggle during a heart cath and then the patient tries to die during a heart cath, are they going for an emergency surgery?
Yeah.
So do they need to be NPO for a heart cath? Yes. So tell me, if they're using dye, do we need to make sure that the patient's not allergic to IVP dye or seafood or anything like that? Yes. Keep them safe.
Patients too.
Yes.
High five. You are, I'm going to tell y'all, she ate something this morning. She is on top of her game. What's the deal with diabetic patients and IVP dye?
Metformin and iodine do not mix. It does not filter through the kidneys.
So take it a step further. If I tell you that and that dye is not good on the kidneys, then what else kind of lab you need to be checking? Okay, and if I taught you in fluid electrolytes that an electrolyte abnormality can cause the heart to be very irritable, would you want to check their electrolytes before you send them to a heart cath?
Yes.
And if the potassium was altered in any kind of way, would you want to report that to the doctor before you let them go for a heart cath? Because a heart cath, you guys, they are literally going inside the heart, touching things. Do you think that might irritate a thing or two? What if they're already irritated from that potassium? Could it kill them? So we're going to be checking BUN creatinine. We're going to be checking electrolytes. I also want to know what that patient's H&H is, because if their H&H is low, what happens if they bleed out? Are they going to be even lower? We're going to be in big trouble. All right, and it would be nice to know, since Kelsey brought this up, they can't clot. What if their PT and INR specifically is elevated?
I'm going to pull the lab panel, please.
Then we're going to need to hold pressure a little bit what? Longer, because we do heart caths on people who have been taking anticoagulants and aspirin and all kind of things.
We give them aspirin before they go for a heart
Right. That's the point I'm trying to make. And so some patients we know are going to be harder to get to clot. So we know we're going to have to hold pressure longer, and we're going to have to be more careful with certain patients, and we need to know that. So that makes sense? Okay, so all that is up here. Now, before someone has a heart cath, we have to have a consent. Oh, dear Lord, I hate that word. You don't do the informed consent. The cardiology, whoever's doing it, does the informed consent, not you. But you witness the signature, right? And it's our role as the nurse to make sure that consent is on the chart before the patient goes. Does that make sense? Okay. So we used to, did y'all hear me say used to? Put Foley's in everybody because we didn't want to be messing with that stuff. We don't do that anymore. Okay? Patients don't get Foley's just because they're having a heart cath. Even women. No Foley. Unless it's specially indicated. Alright? Routinely, we don't put Foley's in people. They have to have a good peripheral IV. Okay? They do not need a central line for a heart cath. You with me? Okay, so what so far did we say the patient needs? An IV. Informed consent. NPO. Check their labs. Make sure they're not allergic to dye. You with me so far?
MPO.
Now let me blow your mind. Let me blow your mind. Jack came in, he had chest pain. He had positive enzymes. It was not a STEMI. It was not a STEMI. He can't go for a stress test. He can't go for a stress test because his enzymes are what? Positive. Elevated. So, but the doctor's ordered a heart cath. Can you go to that?
Yeah.
Yeah. Yes. So don't be fooled by those questions. Because I've seen bunches of those on ATI and NCLEX. They'll say, which of the following findings would contraindicate a heart cath? And they'll put like an elevated troponin or CKMB. And nurses will check that. I'm like, no, we send them all the time to the cath lab with that. So don't, you'll get them mixed up is what I'm trying to tell you. And I can't have you mixing up the stress test and the heart cath. So, if they have elevated enzymes, can they go to the cath lab? Yes. Yes, they can have a heart cath if their enzymes are elevated. All right, so what we're going to talk about when you come back, we're going to finish this, and then we're going to mull through the others. I always do it this way to give you time to catch up with me. So when I start talking about the other stuff, you can follow me or have a question. So tonight, go home, look through the lab, see what, you don't have to know D-dimer and all the UTI crap, that's the clinical. Focus on the heart stuff. Look at this cardiac testing thing I got up here, see if you have any questions so far. We'll finish it, and then we're going to start on the other classroom PowerPoint. Okay? Y'all know the drill? Start doing med cards on the meds that I haven't covered with you. Meds are highly testable when we're talking about 56 questions. 40 on the test or 16. Why do you think I spent so much time on your meds today? Yes.